Hi everyone, thank you for joining me with this presentation called Mastering Atopic Dermatitis. Let's get us started. Here are my conflict of disclosures. So the practical goal of mastering atopic derm is really a good balance between efficacy for our patients and efficiency in our practice because it's such a complicated disease. The three main hurdles to go through is initially getting them clear, which is the easy part, but the harder and harder is to get them to keep clear and keep it up. So a lot of the work is cheerleading that we do for AD individuals. Many of them come in and say, oh, my eczema gets worse with blank. And they are convinced that there's one single trigger for their disease, and they wanted to know the root cause of their symptoms. So it's important for us to let them know that there is simply no known root cause, and we need to design a comprehensive plan for them. So taking care of eczema patients is really easy for entry since it's the most common disease, but it's hard to master. And part of what we do is design a therapeutic toolbox with multiple components for them. And here's my pillar of treating atopic derm. At the top of it is anti-inflammation, followed by skin barrier repair proactively, reconstituting the microbiome using antimicrobials, and finally helping their itch to improve their quality of life. So there are a number of guidelines on how to treat atopic dermatitis based on severity. But when people ask me, when do you start systemic medications? I don't really usually go by moderate to severe benchmark. I say anytime when they're not adequately controlled with topicals, that's when you should start the conversation of moving to a systemic treatment. And we know that there are a lot of treatment options, including sleep management, lifestyle modification, over-the-counter stuff. How do we all put it together? And I use this eczema action plan, which is derived from the asthma action plan with the traffic light scheme of red, yellow, and green corresponding to how severe the disease is. And you want to give them strict instructions on exactly what to do depending on their disease severity. And you can have some skincare tips here that accompany the action plan. And I typically ask them, in the past 3 months, how many days have you spent in each time zone, color zone to get a good sense of how well controlled their disease is in between visits? And I recommend that you invest time to train your medical staff as an eczema educator so you don't have to repeat the same thing over and over again since it's the same message. This will also increase understanding of the disease and help empower your patients. Here are a list of systemic medications for more moderate to severe atopic dermatitis with their dosing. I'll leave it for you here to review. But I want to spend a little bit of time about how to treat dupilumab partial and non-durable responders. So whenever you start dupilumab, you want to give them 16 weeks or more to assess their primary outcome, and that's usually clear or almost clear skin. So if they achieve the primary outcome, great, stay on the dupilumab. However, there are non-durable responders, whether they kind of initially achieved the endpoint, got clear, but partially lost that efficacy. There are also partial responders where they got an improvement, but just not where you want them to be yet. That means they still benefited from dupilumab and you want to stay on the medication. Now, you want to maximize the pillar treatments such as topicals and phototherapy and consider whether they have an acute exacerbation when they are non-durable responders. So if they have it, then you can increase the topical anti-inflammatories and consider IM steroids for severe cases. And you want to consider additional diagnoses as the ones listed here on the right. Once you rule all those out, then you want to consider drug tolerance as a cause for non-durable responders. For partial responders, you want to think about whether they're flaring in between the doses. If that's the case, you can increase the dose or frequency of dupilumab. If that's not possible due to insurance issues or not effective, then you can add other systemic immunosuppressive agents. And here's the algorithm on how to do that. So you can start with cyclosporin, mycophenolate, or methotrexate at half the dose and slowly taper down as needed. Or you can start with 1/4 of the biologic naive patient dose and titrate up as needed. I want to spend a minute on how to transition patients who are currently on immunosuppressive medications for dupilumab. So essentially, you want to kind of mirror the increased efficacy of dupilumab to the improvement in both symptoms and clinical morphology. Typically, within about 2 to 3 weeks, you should be able to decrease the immunosuppressant dose by 50% after you have started dupilumab, and plan to decrease about by half every 2 to 3 weeks or so, with the goal of stopping the immunosuppressive agent completely within about 8 to 12 weeks. And there's slightly different tapering schedule for adults and pediatric patients, as I have listed here. I want to recommend you to look into the provider finder tool on the National Eczema Association to list your clinic here so patients can find you better and sign up for the latest alerts. Last but not least, there's now an Eczema Wise app that was developed by the Eczema Association to help patients track their symptoms, manage their disease, and improve adherence. So this will help both the patient and the providers to get organized and save time. And I will end there on mastering atopic dermatitis, on how to become an expert. And for any additional questions or stimulating discussions, I welcome them at my email here. Thank you so much for your attention.